Welcome. Today my topic of discussion is clinical manifestations of rheumatoid arthritis. As we know that clinical manifestation of rheumatoid arthritis can broadly divided into two parts. Number 1, articular manifestation. Number 2, extra-articular manifestations. Let us discuss. Let us discuss about the articular changes in rheumatoid arthritis. In this picture, if you see the picture properly, I have tried to show the healthy side on the left side and the rheumatoid involved side in the right side. So if we compare with the healthy side, in the right side we see there is synovial inflammation here. Next is the cartilage destruction, and the third one is the bone erosion. These are the most three common pathologies involving in the rheumatoid arthritis joint, and the most three common flag signs of rheumatoid arthritis are pain, swelling and stiffness. And most three important statements of rheumatoid arthritis: the number 1, early morning joint stiffness lasting more than 1 hour that ceases with physical activity. Next, the early involvement of small joints of hands and feet. And third one, the usually symmetric joint involvement with monoarticular, oligoarticular or polyarticular joint involvement. Now this is the hand change. We want to show the rheumatoid arthritis hand change in the right side picture with comparison to the left side picture which show the normal hand picture. In the right side we see here the inflammation in the metacarpophalangeal joint region, proximal interphalangeal joint region and few carpometacarpal joint region. So this type of inflammation occurs in rheumatoid arthritis patient causing this type of hand changes. What happens? What are the pathologies? The inflamed synovium, there is cartilage destruction, panache formation and bone erosion. If we stage rheumatoid arthritis joint changes, we can stage it in 4 stages: synovial inflammation, stage 2 panache formation, stage 3 fibrous ankylosis and stage 4 bony ankylosis. Once again the hand changes, we want to show the deformities. Two common type of deformities: swan neck deformities and bottom ear deformities. These deformities are very common in rheumatoid arthritis patient. In swan neck deformity, there is the flexion changes in the distal interphalangeal joint and extension changes in the proximal interphalangeal joints. Whereas in the bottom ear type of deformity, this type of deformity is just reverse. So there is a extension of the distal interphalangeal joint, whereas flexion changes in the proximal interphalangeal joint. Once again, hand changes. See the ulnar deviation of the fingers mostly occurring in the metacarpophalangeal joint region, which we see here. This is known as the ulnar drift. Let us discuss about the trigger finger. Trigger finger is very common in the rheumatoid arthritis patient. We know in rheumatoid arthritis patient it is not only the joint, it is also the flexure tendon or extension tendon and surrounding synovial sheaths are commonly involved. They are inflamed. Here the nodule is formed in the trigger finger. Nodule here shown in this picture just proximal to the A1 pulley. Now what happens when the nodule is passing through the A1 pulley, proximal and distal position? It causes difficulty. So here in the upper photo, see here the nodule passed with difficulty under A1 pulley during finger extension, and in the lower photo, nodule passed with difficulty under A1 pulley during finger flexion. Now what happened in trigger finger? When the nodule is trapped under A1 pulley, it is unable to pass beyond the inner A1 pulley distally. At that time, the finger remains in trigger finger position. I have shown the picture here. So trapped nodule in flexure tendon. which causes this type of trigger finger deformity, particularly common in the rheumatoid arthritis patient. Now come to the foot changes. Depending on the metatarsophalangeal joint and interphalangeal joints, there are different type of toe deformities like mallet toe, hammer toe, claw toe. Out of these, hammer toe and claw toe deformities are common. In the right side, we see on the upper picture showing the hammer toe deformity and the lower picture show the claw toe deformity, the common in rheumatoid arthritis patient. Next joint change is inflammation of the temporomandibular joint. We see here an inflamed temporomandibular joint. Next come to the cervical spine. Rheumatoid arthritis rarely involves the spine, but in few cases it can involve the C1 and C2 vertebra. What happens? There is inflammation between the atlas and axis, and there will be chance of anterior displacement of atlas over the axis, and there is chance of cord compression. Now we have to remember that real rheumatoid arthritis rarely involves the spine except atlantoaxial cervical spine. Number 2, the distal interphalangeal joints. Let us discuss about the extra-articular manifestation of rheumatoid arthritis. First, we think about the rheumatoid skin nodule. Most common extra-articular RA changes, 20 to 30% of cases, are usually associated with the skin nodule with high level of rheumatoid factor and aggressive disease change pattern, usually symmetric and on pressure points as in elbow, forearm, fingers, knees and heel. Subcutaneous nodule of granulomatous tissue in origin. This firm lump, non-tender, few millimeter to several centimeter. Let us see in picture. Here we see the nodule over the dorsal aspect of the second toes. Here we see the nodule over the heel region, nodules over the elbow region, nodules over the dorsal aspect of the finger region. Now discuss about the vasculitis changes. Another extra-articular manifestation, rheumatoid vasculitis, present in long-standing rheumatoid arthritis cases with positive rheumatoid factor and anti-CCP antibodies, petechiae, purpura, ecchymosis, digital infarct, and gangrene. Gastrointestinal vasculitis may present with abdominal pain and intestinal bleeding. Let us see the pictures of petechiae, purpura, and ecchymosis. When less than 4 mm is petechiae, 4 to 10 mm purpura, more than 10 mm ecchymosis. Once again, the picture of vasculitis of RA in the lower extremity. This is the picture of digital infarct with gangrene in fingers. Next is the pulmonary complication of rheumatoid arthritis. Here we see that pleural effusion or pleuritis is common in rheumatoid arthritis patient. Lung changes. Next lung change is interstitial lung disease pattern, that is non-specific interstitial pneumonia or usual interstitial pneumonic pattern. And the third one is the nodule, pulmonary nodule in rheumatoid arthritis patient. Now come to the cardiovascular manifestation of rheumatoid arthritis. Pericarditis, it is myocarditis. Now the coronary artery disease. Coronary artery involvement is due to chronic inflammatory process, because we know that chronic inflammation causes endothelial dysfunction, which causes entry of the LDL into the intimal, subintimal region, subendothelial region, and collection of the LDL in the intima and converted into LDL to oxidized LDL, which is taken up by the macrophage becoming foam cell, and this foam cell with macrophage and macrophage apoptosis causing fatty streak formation and ultimately atheromatous plaque formation. So coronary artery disease involvement is common in rheumatoid arthritis patient. Come to the eye changes. Regarding eye changes, we know in rheumatoid arthritis there is chance of episcleritis, scleritis, uveitis with keratitis, keratoconjunctivitis sicca or dry eye, xerostomia or dry mouth. These are common changes, eye changes and secretory gland changes occur in the rheumatoid arthritis patient. Now the hematological side, this the anemia is common. Anemia is usually normocytic normochromic type, anemia of chronic inflammation or marrow suppression, anemia of nutritional deficiency or drug effect. Regarding Felty syndrome, it is neutropenia, rheumatoid arthritis and splenomegaly. Associated features or complication of rheumatoid arthritis, first thing is the osteoporosis, maybe due to the disease process itself or maybe due to the drug effect, most likely due to steroid. Hypogonadism due to decreased testosterone, DHEA or LH level, large B-cell lymphoma is a complication. Now come to the constitutional symptom. These are commonly due to effect of tumor necrosis factor, interleukin 1, interleukin 6, which are coming out from the joints when entered into the systemic circulation. These cytokines may cause this type of symptoms. First thing is the fever with malaise. Next, the extreme fatigue. It is depression and weight loss. These are the common constitutional symptoms of rheumatoid arthritis. Thank you to all.